Now we next move on to other talk, our CVA clinic experience by Dr. Sujata from Government Medical College, Thrissur. She is the person in collaboration with the pediatric department in our hospital who started the CVA clinic. Over to you, Sujata.
Good afternoon, everyone. After an exhaustive talk on the assessment of CVA, now I would be sharing our experience at the CVA clinic of Government Medical College, which is functioning for the past 2 years. So my presentation will be involving how we set up that clinic, few interesting case scenarios, and the challenges we are facing. Started jointly by the departments of ophthalmology and pediatrics, our clinic is attached to the Early Intervention Center and Autism Clinic, regional, that is REIC, which is attached to the, which functions in the annex building of our medical college. We all know that REIC is a clinic where a team of different specialists work together to help children with developmental delay. Our CVA clinic attached to this REIC adopts an interdisciplinary approach, which is considered to be the gold standard. That is, a child coming to our clinic is first seen by a pediatrician who rules out any motor, sensory, or intellectual issues, does all the needed referrals, and any visual abnormality, the child is sent to the CVA clinic. And our CVA clinic is surrounded by the offices of the pediatrician, psychologist, speech therapist, and physiotherapist. And all the services a child with developmental delay coming to our clinic is met under one roof, which is greatly appreciated. Our clinic has a very quiet environment, spacious waiting area, and we have all the basic special equipments for CVA assessment arranged in a clutter-free environment. So as Madam already said, the evaluation, very few points. The evaluation of our child in our clinic also starts with noting down a detailed history, medical record evaluation, and then a look into the anterior segment, posterior segment, and refraction will rule out any contributing factors for ocular factors, and also the accommodation lag if it's present. Then we move on to the various aspects of functional visual assessment, like the visual acuity, which may be tested by the LIA paddles. Field of vision, which again, as Madam said, it's usually tested by using a LIA wand, and also contrast sensitivity by using a hiding HD test. We also have other instruments like already mentioned, LIA puzzle, which tests both the dorsal and the ventral stream, and the LIA mailbox. So these are the few aspects of functional, all aspects of functional assessment are assessed. And now this is important to plan the intervention strategies for these children. They are planned putting together the medical history of the child, observing how and when the child is using its vision, and also, as I mentioned, all the functional aspects of functional vision, and also understanding whether the child has any other disabilities. Then the broad principles under which we work are, that is, children with high risk, that is neonatal hypoglycemia, are all screened very early, and also early intervention is advised. And each child with CVA is different, and so we plan a tailor-made approach for each child. And it is always a teamwork between the parents and the therapists. So in very young children or children with profound CVI, we may have to start with the vision stimulation activities. These are done by the office-based therapy sessions or by regular home exercises which can be supervised. Then we always encourage a regular follow-up to further assess, and also to know how much improvement the child has. So the vision stimulation activities can be done in the normal light using a patterned chart or toys, or the environment can be modified by using illuminated toys in a dark room. Then we also do lighthouse activities. You should note that each child, as Mali already said, has preferential light. So each child has his or her own favorite color, and that is being used as the stimulating toy. Then in older children, we plan the strategies according to the problem the child is basically having. And this child, you can see, with inferior field impairment is encouraged to walk down the steps. And the child with optic ataxia is given exercises which improve the hand-eye coordination. So these are the few examples of few intervention strategies. Now we move on to case scenarios. First, to tell us about the importance of early assessment and intervention, and the other two are two of the confusing cases we had last year. So this is a 1 month old boy with a diagnosis of hypoxic ischemic encephalopathy, picked up from the NICU, where our optometrist does weekly rounds. He was advised vision stimulation activities. The parents were very regular in follow-up and also passionate in doing home exercises. So by 6 months of age, the child developed fixation and following. But he then had certain setbacks, like he had seizures, was put on medications, but the parents continued all the interventions, and at 1 year we have a very visually active child. But this child, again with the same diagnosis, it was not so fortunate. She was again also picked up from the same ICU, was advised early follow-up, but the parents brought the child only after 9 months of age. And then due to certain family issues, then we started vision stimulation activities. But now after she is more than 1 year and 4 months, there is no satisfactory improvement in fixation or any visual awareness. So this may be due to the late intervention strategies which were started very, very late. And now the third case is this is a 3-month-old child referred by a nurse from the health center with the concern of child is not looking at mother's face or at any toys. When we saw the child, she had no developmental delay or no other problem, but we noticed that child is not at all visually active. So we again started vision stimulation activities. Then it was noticed that from the home videos they send for review, there is an abnormal movement of the feet. So the child was recalled for the pediatric evaluation, and she had a very abnormal EEG. MRI showed atrophy of brain, and then we did a genetic study also that showed that it is a rare case of autosomal recessive condition which caused progressive encephalopathy and brain atrophy. Now this is an 8-month-old child with no visual awareness. He had some developmental delay, was brought to us. Then, but he in his case, his abnormal seizures and EEG was picked up, and a diagnosis of infantile epileptic spasm syndrome, or West syndrome, was made. Interestingly, we had 2 other children with the same diagnosis. So now we come to the challenges we are facing. Let us see the statistics. For the last 1.5 years, we had screened 68 patients with CVI, and then most common neuro-ophthalmic association is hypoxic ischemic encephalopathy. But let's see what is the amount of low-functioning CVI we are having. That's 59 out of 68 children, and this daunting majority of profound CVI is the major challenge we are facing, because it's very difficult to maintain and encourage these children with CVI and intervention strategies. And then, as everyone is saying, it's a lack of awareness of CVI among the general public, which also includes the medical practitioners, which leads to the late referral. Then the final question is, are we missing out on children with high functioning CVA? Do we need to screen susceptible population like children with learning disabilities, children with minor CNS insults during the childhood? So with this, I'm ending my presentation with sincere thanks to our REIC team and of course Dr. Geeta, who is always a great help. Thank you all.
Thank you, Dr. Sujata, for this